when blood is flowing throughout the body, so near to the neck we have the some baroreceptors here. So they sense the blood pressure is rising and they send the signal to the brain. And above the level of injury, then the brain is able to control the your like if the parasympathetic nervous system will be activated, but below the level of injury, your brain is unable to control. So there will be more chances to like a stroke, paralysis, or you can sometimes it can be lead towards the death. So we call it the this kind of dysreflexic action is the autonomic dysreflexia. So this autonomic dysreflexia means your autonomic nervous system has like is showing the dysreflexic response. So right now, currently, there is no direct way to like monitor this disease, like the episode of this disease. So only the one gold standard to know this whether the person has if the person has a spinal cord injury above the T6 level and the blood pressure is going up above the at least 15 to 20 millimeter of mercury, then doctor may say that you have the episode of the autoimmune dysreflexia. So we know that the like right now the conventional way to monitor the blood pressure is for the cuff based system, which is just we need to utilize this cuff based system, and it will take little time to analyze the blood pressure is going up, and then it is very conventional. Right now, no real time blood pressure like validated system available in the market, and like if like the blood pressure, it has to manually inflate the balloon of the your conventional blood pressure based system. So like it cannot be a real time blood pressure monitoring device. So suppose you want to build like utilize this device for the real time blood pressure measurement, but it requires the manual intervention every time, so it cannot be a real time device for blood pressure monitoring. And initially, when person gets a spinal cord injury, then it will take some time. So he will not aware like suppose he's feeling some headache or something like that. He's seeing that it's a normal system, but he's not aware. But it is due to the autonomic dysreflexia. So it will take some time to recognize the person whether the person like it is due to the spinal cord injury or it's just a normal response from the body. So and also if person get the some trigger, some like infection in the paralyzed part or something is pinching in the paralyzed part, then he will not aware, the brain will not aware like yeah, this is due to the of the episode of the door, because the response is not going flowing towards the brain. Additionally, there are some percentage like about like 40 percentage of individual those are experiencing asymptomatic invisible dysreflexia. That is also a kind of like critical case. So they are the blood pressure is going up and they are unaware about this kind of thing. So challenge was that time that can we develop a system to detect the this dysreflexic episode in the real time. So what we thought like we can if we can recruit several patient of the ID patient or permanent dysreflexic patient, and if we monitor some physiological parameters. Sorry. Mm. If we can monitor some physiological parameters, when they feel the symptoms related to the autoimmune dysreflexia, then we can record some like physiological parameters related to the autoimmune dysreflexia as well as normal condition. So we recruited several patients of total 11 patients that time we have recruited. Those have the cervical or thoracic injuries above the T6 level. And we utilize the Microsoft TM band. And that band can monitor the skin temperature, skin resistance, the heart rate in the real time. And we ask patient if you are feeling some symptoms related to the autonomic dysreflexia, you have the one monitor with you, and then you can press the button. Then you are feeling that symptoms related to the autonomic dysreflexia, so that we can record the your these three parameters from body, and it will be we can some way we can correlate with the episode of the autonomic dysreflexia. So this was the initial thought, and then we like this was the initial. software we provided to them. And they may press button that I am feeling dysreflexic or I am not feeling any dysreflexic episode, and then we can gather the data in the cloud that time. So we gather the data on the cloud, and further we with that data we have applied some classical machine learning algorithm, which like we have the skin temperature, skin resistance, and then heart rate from that Microsoft TM band. Then we with these features or with these physiological parameters, we have utilized some the classical machine learning algorithm. That time we have used the SVM classifier with the radial basis kernel, and then we were able to classify the episode of autonomic dysreflexia and non-dysreflexia with a 98% of classification accuracy. That was one achievement that time. Then further, what was the challenge? The another challenge was like the person who is aware that he it is due to the autonomic dysreflexia or some it is not due to the autonomic dysreflexia, but like if person has invisibility, means he is not feeling any symptoms, then that can be also case. And another thing is that like if person the symptoms inside the body's the AD episode. Suppose in the inside the body the AD episode is beginning, and then it is manifesting in and it is actually feeling by the patient. It has some time delay. So this time delay also can be a critical time delay. And then so we thought is we can utilize some if we can do some experiment in controlled manner, means if we can trigger that AD episode by ourselves and then monitor the see and then see the effect related to the what is happening before the AD and after the AD. So that can be a best case for developing a like algorithm or developing a variable device for those patients. So and um, so what we thought of that time, like if we do experiment on the human subject, that can be like, like triggering episode of the AD, and then this can be critical for this, and then it can be like long term consequences, and it can induce infection to their body, and there can be like impact for them. So instead of utilizing the human patient, we have conducted experiment on the animal like spec Dowley rat, and these rats are very famous for conducting experiments. And the spec Dowley rat, so we have implanted a sensor into the artery of that these rat, and these rat like the implanted sensors was giving us the real time feedback what is going on in terms of the heart rate, your like heart activity, your inside the temperature, and then some way it was giving us the arterial pressure, your blood pressure, systolic, diastolic, and mean pressure. So we have utilized spec Dowley rat, and then after that, like so, the spec Dowley rat has the implanted sensor, and now we want to making like the breaking. We want to break the spinal cord of these rats. So we about the P6 level as it is required for the developing AD episode. So uh, we have broken their like spinal cord above the T6 level, and then another thing we have the implanted sensor. Now we have broken the spinal cord above the T6 level, and for triggering the episode of the autonomic dysreflexia, the trigger should be there. Like so, the trigger how what is the main trigger in that autonomic dysreflexia? It can come from the like your rectum, or it can come from your like below the level of injury. So best way to trigger the episode of the autonomic dysreflexia is colorectal distension. So in the colorectal distension, what we do? So we insert a balloon inside the rectum of the rat, and then when we inflate this balloon, he may feel some pressure, and this will trigger the episode of the autonomic dysreflexia. So this is a very famous method for developing or for uh, triggering the sympathetic response from of the human body. Now it is a pictorial view of whole experiment. Then experiment is you have the spike dolly rat, and then you are breaking. their spinal cord above the T6 level. And so, and one more thing is there, like we wanted to develop a wearable device which should be the non-invasive. So, like we have the implanted sensor about inside the body, and we have also uh, apply some ECG electrodes about the chest of the these threads in the lead one configuration. So you have the electrodes we have applied on the lead one configuration about the chest, so that we can see that in the with that only, like in a non-invasive manner, what is happening in, about the skin, like heart activity or then heart rate, these kind of things we can acquire. And this is a real view of our experiment. You can see here the rat is there, and then it is like we have it is should not move during the experiment. So it is we have some apply some box there, so it will the rat will be on a fix, like he cannot move so much there. And then we there is a some like the balloon is there, and we have inserted into the rectum, and then when we are like inflating that balloon with the particular pressure, then they we are expecting that some episode of the autonomic dysreflexia should be there. And these are the real time recording of your uh, like signals recording non-invasively. So your SKNA signal is the skin nerve activity, and then ISNA is the integration of skin nerve activity, integrated skin nerve activity. And then you have the raw ECG signal, then filtered ECG signal, then you have the heartbeat beats per minute. So these signals we are acquiring through non-invasive. And so like the skin nerve activity is very simple to acquire when you have the ECG electrode in the lead one configuration or any configuration. So typically we expect ECG should come below the for the red for the spec Dowley red, it should come below the frequency should be below the 500 hertz. But when we see the signal above the 500 to above the 500 hertz, then we can expect this kind of signal. So this is a signal coming from the nerve like their sympathetic nervous system response. And in the similar way, like we are acquiring signal invasively with from the implanted sensor, and you can see here that particular episode of the autonomic dysreflexia. So when the blood pressure is going up, when we are trying to inflate the balloon, then and same similar way when the blood pressure is rising, after some time you are seeing falling in heartbeat. Means somehow the system is responding, their internal organs are responding, but not effectively. And this is one episode. Another episode you can see here. This is another episode. The blood pressure is going up, and similar you can see dip here. So means blood pressure is going up means that your sympathetic nervous system is activating, and to counter that nervous system and the response of that nervous system, you have the parasympathetic that is decreasing your heartbeat, so that your blood pressure should be in the um, like acceptable range for the body. It should not like keep on rising. So this is how it is working. Similar way you can see here. So there are three episode of the dysreflexia. So there is skin nerve activity, and this is a particular feature of this integrated nerve activity in the same time duration, and then you have the heart rate. This is the response we are seeing from the implanted sensor, and this is the response we are seeing from your non-invasive electrode configuration. So you can see a similar kind of response we are observing here, and it is coming from the inside the body, and this we are acquiring through the non-invasively using the lead ECG configuration. This is the whole view of the one episode of the autonomous dysreflexia. So when we are starting at like at 60 seconds, we are starting at the inflating the balloon, and we are seeing some rising of the skin nerve activity response here. The bursts are seeing here. Here also you are seeing some burst, and when we're seeing burst, after some times you are seeing the rising of the blood pressure here. It is keep on rising, and after some time, when blood pressure is going up at a certain level, the somehow the your brain will know that it should calm down the heartbeat, this is the only way to reduce the your blood pressure, and then it is getting reduced here. That your heartbeat is getting reduced, so that the blood pressure will again in the like acceptable range. You are seeing here the blood pressure is again going low, and it will be in acceptable range. Okay, and this is the one episode of the autonomic dysreflexia. Here's a more elaborative view of one episode of the autonomic dysreflexia, and there are some features of that. So this is the integrated nerve activity, like skin nerve activity you are seeing here. Just we are starting in the start of the CRD, colorectal distension. We are seeing here some rise of the blood pressure, and then you will yeah, like it is some rise of the blood pressure, and then you will see here. No, this is the just skin nerve activity. We are seeing some burst here, and then your systolic blood pressure is going up after some time, and then your heartbeat is going down after rising the blood pressure. Or this is the one feature of RMSSID, one feature of the ECG, your ECG waveform. So this is there. So and you, if you analyze this graph, like you have the skin nerve activity, it is just when the AD episode is getting triggered, you are seeing just response of this skin nerve activity after 5.6 seconds. And then that's so like both are the like features of the your skin nerve activity, and your systolic blood pressure is going 23.4 second after almost 15 seconds. The systolic blood pressure is going up, means the body will know that blood pressure will go up through the skin nerve activity. So if we can utilize this skin nerve activity feature, and to know that whether the blood pressure is going up or low, and to know the what will happen in next 15 or 20 seconds, then we can initially rehabilitate the person, or we can some give some medication, or some we can like do some physical activity to reduce the blood pressure. So this is very helpful, like for us this was very helpful for us. We thought like we should only utilize the skin nerve activity to see the whether the person has the episode of AD or not. And then further, with, we have um, acquired several features like kurtosis, variance, root mean square, wavelength, uh, waveform length, zero crossing, slope sign change, Wilson amplitude, and then crest frequency. So and we have analyzed, so every time we are seeing some significant difference between the episode of the autonomic dysreflexia and the baseline, or you can see the non-AD events you are seeing here. So that the distribution also you can see here. So every time we are seeing some significant response, significant changes when the person is feeling the episode of the autonomic dysreflexia. So with those features, we have utilized those features, and then we have implemented some neural network architecture. It was some basic neural network architecture, multi-layer perceptron-based architecture. We use those features to train our architecture. And this was the view of that architecture. And after uh, uh, after training of that architecture, uh, we saw some very exciting results. So you can see like we crossed around 95% of classification accuracy, and this accuracy is with that skin nerve activity signal, which is coming before the when the blood pressure is rising. So this is very like useful finding for us. And there is also like we are seeing the lowest false negative, which is 0.07. So this was very uh, like impressive, or you can say the exciting, interesting achievement for in from our lab. That person is feeling the symptoms, and person is not feeling symptoms, but your device is telling that it is an episode of AD, or so that it can be a misjudgment from the doctor or something like that. So this should be low. Your false negative rate should also be low. So this is the result. And then further is we were seeing some correlation. So what I proposed that time, so instead of like your like just classifying the episode of the AD or non-AD. Can we develop a device and the person can wear the device, and then with the device we can monitor the blood pressure in real time? If person has a spinal cord injury and he can wear the device, and that device can monitor the your blood pressure in real time, and from that monitoring of the blood pressure, the person we pressure is going up, and that time he may be asked that, yeah, whether you have the blood pressure going up, or like, or already, like with the help of the blood pressure we can recognize the person has the episode of AD or not. So for developing a like for real time blood pressure monitoring system uh, with the Skinner of activity. So we have developed this architecture, and this architecture was like combination of your CNN layers, then STM, then your densely neural network. So you have the Skinner of activities coming from that electrodes attached to the uh, right, and then you are acquiring some wavelet-based features, and those features you are utilizing for training this architecture, and you have the ground truth which is coming from the inside the body and your arterial blood pressure. So the correlation we achieved for measuring the blood pressure was like 0.72, which was very, it is also a very significant achievement for us. So this can be also a solution for the autoimmune dysreflexia patient. Further, so like now we have conducted the study on the rat, but like actually the purpose was to utilize this study for the human purpose. Those have the spinal cord injury, those are the AD patients. So the study or the knowledge gathered from the rat on the, so we wanted to utilize for the human, like we are calling it the animal to human transfer learning. So the features have acquired from the rat, we can utilize features to directly develop a wearable device for the AD patient. That was the purpose. So uh, now the, so after, like right now the we have just finished the human trial, and then we have recruited some human patient, then and then we have from filling their, to induce the autonomic dysreflexia, we are filling their bladder with the water. And then when the bladder with the water will be filled, then the trigger will be generated for the initializing the sympathetic response in the body. And then before the filling the bladder, we are collecting also a baseline, and this will be, so only we are like doing that only one episode per patient, so there will be no like dangerous situation for them. So we are collecting data, just developing a real-time device for them, and then we can utilize those data for developing a like the real-time blood pressure monitoring, or you can say the classifying the AD and non-AD episode. Similarly, so we have the knowledge of the human of the animal study. So we have utilized that knowledge, and we have same architecture. We have frozen some layers of that neural network architecture. So these frozen layers uh, have been trained using the animal data, and just only last two layers we have utilized to fine tune the with the human subject data, and this will be very fast. This will, like only few neurons are here, so it can be maybe one or two in the only one minute you will have some real time autonomous dyslexia wearable monitoring device for the AD patient. This can be trained. Yeah. So with the training of that, so we utilize human subjects with the approach, and we got around, like mostly we have crossed 90% classification accuracy with the human subjects, and that is like now we have achieved that, like we have some algorithm to directly utilize that algorithm or embed that algorithm for monitoring the autonomous dysreflexic episode for the AD patients. So this work is currently I'm working with the Carl Zeiss, the lab in San Francisco, and we were utilizing some image processing and then in the deep learning to compress the OCT scans. And so these are the OCT scans, the retinal inside the retina, like we can see here, like this retinal view of the inside the human body. Or so, and these are the OCT scans, like some slices of the OCT scans. So when we go to the for like optical coherence tomography, they like this will be kind of some, you will have some retinals, so you will get some images of your retinal view, not directly, like so it will come as a picture. So when we conduct the OCT scan in our eyes, so this will be very very bulky like image. So you will have a GB of data, and if you think about like how many patients are growing like inside a hospital, there are many patients, and the data size will be very bigger for them. So it is very hard to store those high amount of data. So for that purpose, you can see here. So if we utilize some the compression algorithm, it should be like your, it should not um like show some error, and or like it should preserve the diagnostic quality. It should not, like we cannot compromise with the diagnostic quality. So we have the like some algorithms available, like the for the clinical purpose, if they are useful or not, this is very challenging question. So so right now we are developing a like the deep learning algorithm for compressing the huge amount of data into like into the some very minimal amount that should not compromise with the diagnostic quality or the OCT scans. So these are a traditional algorithm for the image compression. So you have the JPEG. We all are about the all are know about this. We have the JPEG 2000. We have the PNG format, TIFF format, GIF format. And this is the architecture proposed, like deep learning architecture proposed by the Google in 2018, Google Research Lab. And this is a particular deep learning architecture for the image compression. So this is accepting the RGB image, and you will have the compressed image. You will have the compressed information, and then further you can decompress that information, and then this information, like you can store the like your whole entire, like suppose you have the 1 MB of your image, particular image, then you can store in that 1 MB of image into 20 KB or something like that, like almost like 2% or 3% you can you can reduce that information. So what is happening in this architecture, you have the input image, then you have the encoder, which is inside that encoder there are several CNN layers. Then you have the hyper encoder, further the information which is reduced through the encoder, further it is being reduced by through the hyper encoder, and then we are quantizing it, and further with the arithmetic encoder we are saving those bits. Okay, then these bits are we are saving. Also, we are saving this like quantized encoded your y value here, and with this saving with the bits of the your hyper encoder and your encoder, we can utilize the only these bits to reconstruct the your image. Again, reconstruct the image. So this information will be in compressed format. So you have the um, so what is happening here? You have the context model here. So with context model, you are already giving some context to, like it's a deep learning architecture. Means your context model is also being trained. The context model is getting recognized what can be the next pixel, what can be the next pixel every time it is getting recognized with the help of the past pixel values. And with the entropy factorized entropy model, you are distributing, you are just applying the entropy encoding model here. You are thinking that and all the information in the Gaussian distribution, and with this manner you are saving. And when this information passes to the arithmetic decoder, in this decoded information will go the hyper decoder, and then you will have the some your entropy parameters, your mean and scale, your entropy parameter mean scale, and this context model will further fine tune your entropy parameters. Then you will have the fine tune and entropy parameters. These entropy parameters will help to reconstruct the image with the quantized like encoded your y values. And with the decoder, you can reconstruct the image. So we have utilized this particular architecture, and you can see here this is the one of the slice, like OCT scan slice, and this is the original image, and this is a reconstructed image. So you'll not see any significant difference between the your like original and your reconstructed image. The data size was only 0.85%. The reconstruction, your compressed data size was only 0.85%. And this another is a scan. You have the reduced to the 2.3%, only 2%. Where you can see here the original and reconstructed image. Further, this is another example. So the flow image is a flow image. So you will see here like original and reconstructed.